and come to the immediately to the topic which I'm going to be speaking on today. Where these disclaimers, first disclaimer is that obviously this is an online platform and the topic which has been given to me, I'm sure the people who actually take this topic can spend a whole day or a day and a half to be completing this topic. And I'm going to be doing it in the next 45, 50 minutes. So I must tell you that I am only trying to sensitize the postgraduates in our specialty how to be doing this particular clinical trial. Obviously, my endeavor is only to sensitize you. Details I may not be able to give you, but I'm making sure that at least I'm covering all aspects of how would you want to, if you are interested in doing something like this, how would you want to do it? But obviously, the details may go missing. And most of my presentations are based on evidence based, but obviously, my experience also. So you will, as I would speak across through the span of the lecture, you would understand what I mean, that this presentation is both a mix of evidence and experience. If you just tag this and type this in Google, the word evidence, you would find that there are a lot of things which come up, right from relationship to kind of evidence-based rehabilitation, to evidence-based strategy, to fashion, to approaches in legal, in base technology learning. This term is being used everywhere. So we really need to understand that why do we need evidence in all spheres of life? Uh, if you really understand this point, that when we generate some evidence, it is there to help us to prove that something is true or not true. That's the reason that whenever you see this term evidence, it will be trying to tell you in context to that particular subject or that particular topic, whether that particular things in that is true or not. And this is what we exactly mean by evidence. And the next pertinent question is that why are we looking at generating evidence or having an evidence-based medicine and evidence-based dentistry? It's absolutely simple. Uh, is just our one aim is to provide the patients with the best possible treatment options and care. So frankly, we are looking at generating evidence in our endodontics so that we can give our patients the best possible treatment options and care. And that is why we are really looking at generating evidence in endodontics. Now, if you come down to medical or endodontic or dental field, how do we generate evidence? Now, there is a pyramid for level of evidence, and you can generate evidence through animal or in vitro studies. You can generate evidence by publishing case reports and case series, or you could also do case control studies, cohort studies, RCTs, and you could do a meta-analysis or systematic analysis of those randomized controlled trials. So if you can see this pyramid, as you go up, the level of evidence goes high. And in our understanding in endodontics, if you're really looking at creating a high level of evidence for any aspect in endodontics, then you're really looking at conducting a randomized clinical trial. So I'll just recapitulate to what have I said. I told you that evidence is required in all spheres of life. We require evidence so that we can give the best care and treatment options to our patient. And I told you in endodontics, you can generate evidence through bench studies, that is the laboratory studies, or you could publish case reports. But as far as the highest level of evidence, if we're really looking at generating for any aspect in endodontics, is by creating a randomized trial or by conducting a randomized controlled trial. And that is my topic today, that importance of clinical randomized trial. And I would be wanting to tell you that how would you be looking at conducting that trial is my main aim. The topic, which if you see the brochure says the importance, I've already told you the importance. Importance is re-emphasized that we're looking at giving our patients the best treatment options by the evidence which we generate through these randomized controlled trials. Now, if you are really looking at what do I mean by randomized clinical trial? As I said, among all the trials, this is one of the most robust form, and it involves random allocation of subjects to various treatment arms that are being compared for their effectiveness. They are considered as gold standards and provide the highest level of clinical evidence among any type of primary study design. So it's considered as a gold standard, highest level of evidence, and basically it involves random allocation of subjects to either the control group or the intervention group. The same thing if you go through the dictionary, the medical statements dictionary, it's the same, but the words are being changed, but has the same meaning. It's one of the most powerful tools in clinical research, as it says. As far as the residents are concerned, postgraduate students are concerned, you'll need to understand there are many types of randomized clinical trials. And you can see that I have tried putting in based on patient exposure and response to intervention. So basically, if we're dependent on the patient exposure, you can have a parallel design, a crossover design, or a factorial design. Now, a parallel design is where subjects are allocated randomly to the treatment or intervention group or the control arm. A crossover design it's basically a two-arm trial where patients are initially allocated to one of the two groups. One group is assigned to the intervention, and the second group is not assigned to the intervention. That means it acts as a control or a placebo. Patients from both groups then undergo a period of washout. That means the trial is stopped at that period of time, and both the patients in both the groups are given a wash-up time, and then the subjects then cross over into the other group, and the trial continues. The benefit of doing a crossover design is that it reduces the variability. And the third type is the factorial design. It's an experimental trial that simultaneously tests effects of more than one intervention in the same time. Now, this is for theoretical part. Just to tell the postgraduate residents that as far as the endodontics is concerned, is the parallel designed randomized clinical trials, which are most of the times conducted in our field. See, crossover designs are usually when we're looking at testing some drugs or something, and the parallel design is when we are trying to test most of the things in our related to our field. So just get this message that among all the types of the RCTs, as far as endodontics is concerned, we're really looking at conducting most of them in parallel design. And as that's what I've actually said, that parallel designs, randomized control trials are the most common as far as endodontics is concerned. So I hope that you've got this message clear that we do have different types of trials as far as RCTs are concerned, but the parallel design is something which we routinely conduct to generate evidence as far as endodontics is concerned. If you're looking at doing a randomized clinical trial, as I already said, it's the gold standard. You need to develop a research question. So the first thing which must come to your mind is to have a research question. No RCT can be completed if you do not have a valid research question. So the first thing which I thought I must tell the postgraduates is how to develop a research question, because I find it a lot of times that they take a kind of article which they call it as a master article and then say that we are trying to do something related to this. Now, that's not the real research. That is re-research. So if you're really looking at doing an original RCT, you must have a research question, a valid research question, and that is why I need to tell you how would you want to develop a valid research question. Always select a broad topic initially. So initially, if you're really looking at developing a research question, search a broad topic. And obviously, it has to be of interest to you and to your guide. So make sure that you first take up a broad topic, and I'll give you an example in my next slides. But just understand that if you're looking at developing a research question, first have a broad topic in mind. It should be of interest to you and to your guide. And obviously, it should be a thrust area in today's time. I mean, doing some research which is not a thrust area may not be expected or accepted when you are looking at publishing your research. So that should somehow be able to answer the questions which we are really looking for answers during this phase of research. And that's what I said, that would really help you to get your chances of paper publication more. So now let me tell you what I meant when you would want an broad area. So cryotherapy, for example, is a broad area. Now try and read all articles about cryotherapy in endodontics, and then when you have read all these articles about cryotherapy in endodontics, and if you think that cryotherapy is an area of your interest and it is an area of your interest of your guide, then probably try and see that can I use cryotherapy in any other field of endodontics? You see, cryotherapy, if you see all the articles right now, have been used in kind of endodontics for reducing pain. So the only thing which you would now want to see is, can I use uh, cryotherapy in any other field, uh, say pulpotomy. So what you're doing, you read all, it's a broad topic, cryotherapy, and you read all the articles, and now you come to the conclusion that this is an area of interest. Can I use cryotherapy in any other field of endodontics? Now consider pulpotomy. So your preliminary research question is that, look, cryotherapy has been used successfully in root canal therapy. Can I use it somewhere else? Then you say, okay, let me try and see if I can use cryotherapy in pulpotomy. Now that becomes, as I said, a preliminary research question. It's not a final research question. You're just putting up, after having read the literature on cryotherapy and seeing that cryotherapy is mainly used for pain, can I use the properties which are there in cryotherapy for something else? And then you say, okay, let me see if I can use it for pulpotomy. Then you are supposed to go, after having formed a preliminary research question, what you need to do next is to go search the literature, that means review the literature. Now, if you're really looking at reviewing the literature, you must use mesh terms. You see, if you use the mesh terms, that is basically a controlled and hierarchical organized vocabulary which has been produced by the National Library of Medicine, and you are supposed to use the mesh term, because if you do not use the mesh terms, then probably the two things can happen. Either you're not going to come across the right articles, or you're going to miss some of the articles, because most of the PubMed journals in their title only use mesh terms. So if you do not use mesh terms in your search, so as I said, either you're going to miss those articles or you're not going to find the right articles. So if you're really looking at searching in PubMed, you need to have the mesh terms, and mesh terms are there for you to understand that if in case you have mesh terms for pulpotomy, then it is pulpitis, permanent dentition, cryotherapy outcome. So these are the mesh terms which I would want to search on my PubMed, so that I can get the relevant articles and the best articles. Once you've searched with your mesh terms, then you can use free text terms which are not mesh terms, which are irreversible pulpitis or MTA, so that you can broaden your horizon of your search. Again, as I said, we cannot go into details, but the only message here is that once you have your research question, and when you want to do your review of literatures, you would need to use mesh terms, and then after the you would need to add your free text terms, so that you can get a broader search, and you can get the articles which you require. As far as the review of literature is concerned, or the search of literature is concerned, it must comprise of the present, what is happening. When I say present, in the last 5 years. When I say past, it is the last 10 to 15 years, and very present is 2 years. So all those articles must be there for you. The present is in the last 1 or 2 years. The very present is last 1 or 2 years. The present is in the last 5 years, and the past maybe 15 to 20 years. Is that what you're really looking at searching the articles, so that you do not again miss the relevant articles? May the research have already been done, and because you did not search too past an article, or the very present or the present articles, you may have missed them, and you may think that this is an original research question, but it happens that somebody already has conducted the research. So once you are sure that you've done the review of literature or search of literature very, very finely, in the sense by using mesh terms, and gone to the past, the present, and the very present, and if you do not find anything in the literature, then that becomes a true research question, and that becomes a lacuna in literature. Now, that also you need to understand that I've done, I started with the preliminary research question, used my mesh terms, made sure that I've searched the articles in the past, the present, and the very present. I did not find anything. Now, I confirm that from my side, that's a true research question. And from my side, that becomes a kind of lacuna in literature. And just to exemplify, then I come to the understanding that there is no study in the literature that has evaluated the effect of cryotherapy on the treatment outcome of full pulpotomy in mature permanent mandibular molar with symptomatic. May it had been done in root canal therapy and outcome and pain, but I do not have any study on pulpotomy. Now that becomes a lacunae in literature for me. Now, still, you need to validate this research question with your mentors and colleagues, because I've understood that I may think that this may be a meaningful or a valid research question. I've searched the literature, there is nothing there, but that could be because it may not have been a valid research question. That is why nobody has worked on it. So once you're sure that nothing is in the literature, you need to discuss it with your mentor, that is your guide, and your colleagues, that look, I'm planning to do my original research on this. Do you think it has meaning? When your mentors and your colleagues say, okay, guys, this is a meaningful research, that is the time you are having a validated research question. So from starting from preliminary to the true research question to a validated research question is how I would want you, out of my own experience, build your research question. Once you have built your research question, you have to make sure that it is according to the PCOT format. You will really need to understand that what population of the patient you're looking at, what intervention you're looking at, what comparison or control you are looking at, what is the outcome measures, and you are looking at getting it, and at what time period are you looking at. Now, once you answer this, your title or your research question is ready. The final research question, you would understand, read it. I don't want to be reading it out for you, but if you read it, you will understand that it is fulfilling the PCOT format, and everything is there. So your research question now, from a preliminary to a validated to a final research question. Now, that is what I would want you to develop as a habit if you're really looking at doing some original research, and make sure that your research question fulfills the PCOT format, please. So this is where I am summarizing to you as far as the research question. You would ask me, why did I spend so much time on a research question? Because guys, if your research question is not proper, you're, even if you end up doing a randomized clinical trial, it's never going to answer what you really wanted to, because the research question wasn't probably valid, it wasn't probably searched for. So please make sure that you spend enough time in reviewing the literature, talking to your mentor, and then only freeze your final research question. The next thing is the hypothesis, is with, as I said in the beginning itself, I'm really looking at just sensitizing you that what all should be there when you are looking at developing a randomized clinical trial. Obviously, as I said in the beginning, 1 hour is not much for me to go into details, but just to make you understand what is hypothesis is, in simple terms, as I said, a statement derived from the research question predicting the research outcome. Try and understand this statement, a statement derived from the research question, predicting the research outcome. That is what exactly is what I mean by an hypothesis. Now, the hypothesis could be a null hypothesis or an alternative hypothesis. Basically, a null hypothesis is a form of a hypothesis that is deemed true until proven wrong based on the experimental data. It states that there is no difference between the groups which we are testing, whereas the alternative hypothesis is basically stating that there is a real difference between the two or more groups. Usually, we work with both the hypotheses. That means in our when I would be making my thesis or a randomized clinical trial, I would be writing both the hypothesis, the null hypothesis saying no difference between the groups, the alternative hypothesis saying that there would be a real difference. And this would only be told to me after testing these null hypothesis and the alternative hypothesis by a statistical analysis at the end of the randomized clinical trial. The results of them, when they are statistically analyzed at the end, would I know whether my null hypothesis was accepted or my alternative hypothesis was accepted. But at the start of the randomized clinical trial, I'll have both the hypotheses written, and the one which would, at the end, one of them would get rejected. I hope I make this point clear to you. Just to exemplify only that, taking the example of cryotherapy, you would see this throughout the paper, throughout the presentation now. The null hypothesis is that there would be no difference in the treatment outcome when I'm using either cryotherapy or hypochlorite. So there's going to be no difference, null hypothesis. But as far as the alternative hypothesis is concerned, because 2.5% is already kind of a gold standard, I am trying to test 2.5 degrees centigrade cryotherapy. So I would end up as an alternate hypothesis that look, the cryotherapy at 2.5 degree would be a better choice or a better alternative to 2.5 hypochlorite for the outcome and hemorrhage control in teeth with the similar diagnosis. Which one? I am going to be working with both the hypotheses. Which one is going to get accepted, which one is going to get rejected, will only be told to me when I have completed my statistical analysis of the results which I obtain. As far as the title of your thesis or your randomized clinical trial is concerned, it should never be too long. I specifically talk from a paper point of view. Should never be too long. It should be brief. Must have the major key terms. As I said, if you're looking at publishing it, the mesh terms should be there, because if somebody is searching with the mesh terms, and if you don't have mesh terms in your title, that person would miss your article. So please make sure that you have a brief information about your study, and it should have the mesh terms, and never use abbreviations in your title. Always have the aim of your study being reflected in your title, and it should always have this clear indication that it is a randomized clinical trial. These are the three things which you would want to have it in your title. It should be brief, should have the title, should have no abbreviations, and should mention in the title itself that you are having conducting a RCT. If you see this, you exactly would know what I was trying to say. It's brief, it has mesh terms, and it clearly says that I'm doing a randomized control trial. Now, that is how I would want you to have the title of your study. Aim is basically what of the study, what the researcher intends to do. It's always a broader perspective of the topic. It's a broader perspective, but this aim is what am I looking at doing is in a broader perspective is what the aim should mention. I will exemplify again at a later stage. You can see that it's there. My aim of this study is to evaluate the effect of cryotherapy on the treatment outcome of full pulpotomy performed in mature permanent mandibular molar teeth with. So it's broader. It's absolutely broader. I'm only trying to say that I'm looking at the treatment outcome. So it's what of the study. What of the study in a broader perspective is what I would try and explain the aim to be. When I come down to objectives, it becomes a targeted perspective that how am I looking at achieving those, that aim which I have put as a broader perspective is what I am looking at as far as the objectives are concerned, basically to break down the broader perspective into a targeted perspective is what the objectives are. It is always said that the objectives have to be smart in the sense it must be able to, my ultimate goal is to have that aim being answered. Now, as I said, aim is a broader, it's a targeted perspective, is the objectives. And if you're really looking at answering that aim of the research question, then you must have your objectives smart. Now, that is where this acronym comes. Be specific. That means you must be sure that how am I looking at answering that aim. It has to be measurable. Obviously, your goal should be able to be quantified and track progress or success. It should be attainable. Obviously, it's realistic, and it has to have the resources. So if you're looking at doing that, means that patient pool should be there. If you're looking at doing a kind of a biomarker study, then you must have the PCR with you. And obviously, as I already told you, it has to be relevant. That's what makes your objectives smart, and it has to be timeline. It has to have a deadline. You cannot continue. So again, to emphasize that aim is a broader perspective of the study. How you're going to achieve that aim is what comes to a targeted perspective, those objectives. And as I said, the objectives have to be smart in the sense they have to be specific. That's more than important. And obviously, if I can't measure them, it's no use. The objectives also you can put in your trial as a primary objective and a secondary objective. Now, the primary objective in this particular study, which I'm exemplifying, is I'm only looking at the clinical and the radiographic outcome. So that's my primary objective, that if I use cryotherapy, how is it going to impact my clinical and radiographic outcome? But I can also try and study whether there is a difference on the time taken and the postoperative pain. You can make them into a secondary objective. Now, you may change depending on your understanding or what you are looking from that study. You may make this time taken to achieve hemostasis as a primary objective, or the postoperative pain to be the primary objective with cryotherapy, and make the radiographic at the end of 1 year or 4 years as your secondary objective. Now, these sometimes are interchangeable. I've just tried to explain you because I was trying to explain from the beginning that in this particular exemplified case, I'm looking at the outcome at 1 year. But if I'm looking at seeing, is there a difference in the time taken to achieve hemostasis with cryotherapy or hypochlorite? Now, if that's my primary objective, that can be a primary objective. But you really would need to understand at a long term that how am I looking and making this. The only thing which I need to tell you guys is that please, I see a lot of theses, maybe a randomized trial. They have too many objectives. You see, ultimately, all your statistics would be dependent on your objectives. Now, if you have too many objectives to answer through one single study, I'm telling you, at the end of your study, you are only going to get confused and not being able to produce the desired results out of the study. So please try and answer the minimum number of objectives, maybe one or two, a primary and a secondary objective from one trial. Don't mix it up. Otherwise, you will never understand. You'll never be able to put 2 plus 2 if you have too many objectives. Never able to defend these studies is my experience. So please keep your objectives to the bare minimum. As far as the methodology is concerned, what I need to tell you is that don't miss your ethical clearance, because if you don't have an ethical clearance, when you go in for one, it's not good to do a trial without an ethical clearance. It's unethical work. But what would you have a problem is in your publication, because any publication would ask you to have your institutional ethical clearance. So make sure, and now at least this part is mandatory and we do not miss it, but just make sure that you have. This is something which we are still missing in a lot of colleges. They are doing good observational studies or doing a trial, but they end up forgetting to kind of register with the CTRI. Now, that's also become mandatory if you're looking at publishing the trial at a later stage. So must have an ethical clearance, and your trial must be registered with the CTRI. and you must be updating that CTRI website, because that is where then only can you claim that your study has been done ethically and on as per the protocol which was originally registered with the trial CTRI. So please don't mix it. The second thing which I would want to tell you in the methodology is that to have your inclusion and exclusion criteria, really thought about it, because selection criteria basically dictates which subjects are selected for a trial based on specific inclusion and exclusion criteria. This is done to make sure that the various treatment arms are similar as a consequence of being selected using identical criteria. But the only question here is that please have a good inclusion and an exclusion criteria. You need to be strict, but at the same time, you need to be flexible. I try and explain you that when I'm planning a study like this, if I keep my age group to 16 to 20 only, then the number of patients which I would probably get are going to be very less. So make sure that you are flexible as far as your age is concerned, with an understanding that pulpotomy, there is no effect of age. So even if I make it 18 to 40 or 16 to 50 is not going to make much of a difference. But what am I doing? I'm increasing the pool of patients which I can recruit. So please make sure that you are kind of liberal with few of your criteria. Obviously, they need to be strict, but make sure that you do get all those cases which are there. Now, we also do understand that the outcome is not getting affected by deep and extremely deep caries. So you can add both of them rather than just having deep, as I've showed. That is the way. What I mean that be flexible in your inclusion criteria, be smart in the beginning itself so that you're able to fulfill your sample size. Otherwise, we've ended up understanding over a period of time after having done RCTs that when our inclusion criteria become too narrow or too strict, we are unable to fulfill the sample size. So again, as I said, you need to be smart here. You need to make sure that there are no confounding factors getting affected, but at the same time, to complete the sample size, you have a little more flexible inclusion criteria than what you would want to have. And obviously, this is an example which I wanted to show. Keep out bizarre inclusion criteria. We really don't have any indications of keeping such inclusion criteria like these. So make sure they are flexible, but at the same time, they are keeping out all the confounding factors. This is important. This is important. Sample size. You see, you need to have an appropriate number of participants recruited to a trial in order to detect the presence of a effect. You see, you already wanting to know what is the time taken to achieve hemostasis with cryotherapy or with hypochlorite. Now, if you're looking at somewhere kind of being able to surely say that, look, it does have an effect or it does not have an effect, you'll only come to know if you have sufficient number or an appropriate number of participants. And it is always supposed to be determined before the start of the study. Now, the sample size is directly impacted by your primary objective and obviously sometimes even with your secondary objective. That is why I say make sure that you keep your objectives very, very straightforward, specifically the primary objective, and keep your secondary objectives limited. And obviously, it also depends upon the design of the study. If you're looking at doing a superiority or a non-inferiority trial, the sample size get affected by this. So sample size is very, very important. This is again something which we miss when we are making the design of the study. And that is where I have noticed that the chances of the study getting rejected at the time of publication goes down, citing not sufficient sample size. So make sure that you get your sample size calculated. And as I've already said before the start of the study, now, how to calculate a sample size? I'm not going to go into details. One, I'm not a statistician, and I always depend on a statistician for determining the sample size. But what do I tell my resident how to do a sample size calculation? The first thing is that he has to review the literature and take out studies which have similar outcome measures, So if you're doing a pulpotomy study on the outcome, if there is a similar study which has done something different but have had the similar outcome measures, you can take the success rate of either of the procedures from there and take those as a reference and ask your statistician to develop the sample size for you. Now, what I want to tell you here is that please take it to a statistician who has interest in dental trials. My understanding and experiences here is that the trials which we end up doing and publishing are a little different from the trials which our medical colleagues do. And our statisticians who are trained only in the medical field have a different thought process as far as developing a sample size is concerned, or that's my experience. So I always say that please go to a statistician who has an understanding about dental trials, endodontic trials, who has a background where he has helped the dental students in the past. With that article which you have found for him, he would probably understand it better, set the power of the study, set the alpha error, and develop a sample size for you. That's what the message here is. Take the right article, a recent article on the same topic with the same outcome measures, take it to a dental related statistician. He would help you to get you the right sample size. In case you do not have any related literature, please do a pilot study. A pilot study with 10 patients also is sufficient enough to see the success and failure, if you are looking at success and failure. And you do not have to have an endpoint at 1 year. So if you do a trial, a pilot study for, say, 10 patients and see the endpoint at 6 months, and if you get a trend that what is a success and failure, you can take the same success and failure to your statistician. He would be able to develop a sample size for you. Again, this is something which we personally done in few of our randomized clinical trials where we had no literature. So we did a pilot study, as I said, into a curtailed outcome period, a curtailed sample size, saw what was the trend as far as success and failure is coming out in that pilot study on that limited sample size, took it to the statistician, and he was able to help us to, to develop a sample size for our main randomized trial. Message here is whatever you need to do, make sure that you get the right statistician to do the right sample size. Otherwise, as I said, the use of sample size calculation so that I am able to take out the effect will never be proven. You'll never have the real results. You'll never get a publication. You'll never be able to add to the scientific literature if your sample size is wrong. Randomization is again something which I would want you to have your points here. It's basically making sure that equal chance of them are being selected for each group. So there is no bias. So randomization is a hallmark of a randomized clinical trial, and it makes sure that the patients are randomly allocated and each one of them is being selected for each group or a different group, and there is no chance of, or probably reduces the bias. Now, again, if you look at, there are many types of randomization: simple, block, stratified, minimization. The ones which we usually end up using in our field is the blocked and the stratified, the kind of randomization. Simple, yes, is basically the simple randomization is on a single sequence of random assignments, and it's very helpful to just maintain complete randomness of the assignment of a group to a particular group. One of the most common ways is just flip a coin. But as I said, in randomized clinical trials in endodontics, the ones which we are doing most of the time is blocked randomization and stratified randomization. We really do not do the minimization. As far as the blocked randomization is concerned, in these the subjects are grouped into blocks with the different treatments to be tested randomly assigned to these units in each blocks, specifically used when your sample size is small. And that's where endodontics, we don't, I mean, obviously it's not possible for large sample size. And so most of the times we end up using blocked randomization. Stratified randomization is also useful because if I may exemplify, if you think that the age is going to make a difference, then I first subgroup those age also, and that's a type of stratified randomization. As I already said, I am only sensitizing you at details you'll have to go through, but the maximum which we use is blocked and stratified randomization. The next part of randomization is sequence generation and the allocation concealment, which you must understand. Sequence would be generated by a statistician, either by using a random number table or by using a computerized random number generator. But you must know that it has to be done. A sequence generation specifically for the block randomization has to be done. And as I said, it could be done either of the ways, and it's going to be done by your statistician. You must use this allocation concealment. It is very, very, it's the best way of doing it. Obviously, this is the only way you can really reduce the operator's bias, and snooze is the most prevalent, most simple, that is sequentially numbered, opaque sealed envelopes is there. And as I said, this is the only way you can prevent the selection bias based on the operator. So you cannot skip this step if you're really looking at doing an ethical kind of an RCT. As far as the controls are concerned, you would require to have the experimental group, obviously, and a positive control and a negative control. Positive controls are a must. It is basically that it is being exposed to a treatment plan that is known to produce some effect. So it's almost like a gold standard. So to exemplify, my positive control in this study would be 2.5% sodium hypochlorite, because 2.5% sodium hypochlorite is being used in all the studies which are dealing with pulpotomy as far as hemostasis is concerned. So it's almost like a gold standard. We are knowing what the results of using this solution on pulpotomy would result in. Obviously, the experiment is, what am I testing in this randomized clinical trial? And in this case, I'm testing cryotherapy. 2.5 degree distilled water for 10 minutes is what I'm doing as far as cryotherapy is concerned. Negative control is always good to have, because it's not going to receive any type of treatment, or maybe a placebo treatment, or a solution in this case, which is not going to make a difference. I know that by using irrigation and normal saline is not going to make a difference. So it's basically it is done. It is there to make sure that you have the unknown variables, to control the unknown variables during the experiment, and to give the clinician to compare his results with the test group. So, but the positive control, or the test and the positive control, have to be there. That is the experimental, the test, and the positive control are a part of your randomized clinical trial. Negative trials, sometimes they do insist that you must have had a negative trial, but you can still defend of not having a negative trial. But a RCT cannot be possible without a positive control. So you must have these two also in your mind when you are developing your randomized clinical trial. As far as the clinical procedure is concerned, I have 4 or 5 points, which I must tell you. You really need to be blinding, your process of blinding. So, because that's what is something very important when you're doing a randomized clinical trial. Now, any one of them or all of them can be blinded, actually. And again, blinding is a very, very vital role for ensuring that this trial is being validated. Now, based on blinding, you can have an open RCT. That means everybody, right from the patient, the operator, the outcome assessor, everybody knows what's happening in the trial. In a single blinded root canal RCT, you really are only having the patients who are blinded, and double blinded randomized clinical trial where the patients and the and the operators or the outcome assessor. So either the operator or the outcome assessor is one who is being blinded. In triple blinded randomized trials, all three, that is, the patient is blinded, the operator is blinded, and the outcome assessor is blinded. Now, in our experience, most of the times we are only randomized trial. Specifically, the patients can be blinded and the outcome assessors can be blinded, but blinding the operator in our field is somewhere which I have always been not been able to do. So most of the times, I would prefer to do a double-blinded randomized clinical trial. That's the best. So most of the randomized clinical trials which you would see in the literature would be double-blinded, please. Obviously, as far as the methodology is concerned, you're really looking at following a standard methodology. If the standard methodology exists in the literature, then make sure that the standard methodology is published in a standard journal. Please do not take non-PubMed journals to take sure they are peer-reviewed, high-impact journals where you are taking the standard methodology. If you do not methodology and if you're trying to propose your own methodology, then you will have to background with a pilot study and make sure that that methodology is standardized before you can take it up for your randomized clinical trial. Now, that is where the role of the PI comes. I must tell you here that the most of our trials, if they are being done by postgraduates and if the methodology has to be standardized, the PI's role is that they must in first few 4 or 5 cases show them how the standardization of the procedure needs to be done. Now, that's the role of the PI to train and calibrate the operator. Always use standard materials and equipment because that would be very, very simple to defend your trial, because if you end up using non-standardized or not accepted materials, then you may have to always keep answering to the peer review people that why did you not use this specific material and why did you, because they may think that this particular material may have had a different outcome. So please, if you're really looking at doing a high standard trial, make sure that you end up using standard materials and equipment and not compromise on that. You would really need to be making sure that every case in the trial is elaborated and it is documented properly, because today's requirement in publication is that you need to submit the entire data of all the patients to them. And obviously, if somebody is looking at repeating your methodology, that has to be well explained. And if it has to be well explained, you should have been doing it well and probably documenting it well, is what I would want to tell you as far as thing is concerned. In the methodology or at the start of the study itself, you'll have to get the outcome endpoint clearly defined. Whether am I looking at 1 year or 4 year? Most of our theses end up at 1 year. That point we really understand. But if you're really looking at developing high level of evidence, then most of the trials have an endpoint at 4 years. But most of the time, PG thesis, in our experience, does not go up to that time period. Usually it's 1 year or 18 months. But as I said, if you're really looking at the right evidence, then the endpoint in endodontics should be considered at 4 years, not at 1 year. But this has to be defined at the beginning of the study. As far as the outcome and outcome measures are concerned, you can see that you really want the outcome should be there, which is able to answer the question being proposed. So basically, it should be able to answer the aim with which you started the study, and it should be, the choice of outcome measures should be such that they will be comparable to other research, and obviously these have also been defined before the start of the study. If you are having the clinical outcome criteria, you cannot change them during the study. You will have to define that I'm looking at pain, I'm looking at periodontal or tenderness or percussion. These are my this is the pain scale which you're going to be using. You cannot change during the course of the study. And if you're looking at doing it at 2D, then you will have to define that, look, I'm going to be doing it on 2D as far as outcome is concerned, and I'm going to be looking at root resorption, I'm going to be looking at furcal, I'm going to be looking at periapical pathosis, and I'm going to be defining the periapical based on periapical index. And if I'm looking at narrowing of the root canal or obliteration, you will have to define it at the beginning of the study, then what would be my clinical and radiographic criteria. As far as the outcome assessment is concerned, the only point which I need to tell you is that you are really looking at the people who are going to be reading your radiographs to be blinded, and they have to be trained and calibrating so that they're on the same page. If somebody is reading it as PI1, the other should also be reading it as PI1, and you must do a kappa analysis at the end, so to make sure that your reliability and agreement between two or three of the assessors is there, then only the trial is considered as valid. Make sure that you are doing the data collection and entering into the Excel sheet completely. Please do not miss any data of your patient. Everything should be there. Note it down, because when you would require that, we really do not know. So please do not miss any data collection. And once you have the data collection, you need to get back to the statistician. My humble request to all postgraduates is make sure that you have a co-guide who is a statistician. Then my experience is that they've always been more helpful if they've been co-guides. It is their responsibility. So go back to them with your complete data, and with your aims and objectives of the study. Go back to the statistician. He'll help you to tell that which statistical test would be the most appropriate to define the groups and to compare the groups, and if there is some group analysis, be what type of test would be applied there. As far as the residents, again, please, this message is clear that the negative is as important as positive results. As I said, we are working with both the hypotheses. So when you're collecting your data, be very, very ethical. Please get the same data, what you saw, be there with you, because you have to understand that it's an RCT, which is you are trying to generate highest level of evidence. And with your generated evidence, somebody would be treating a patient somewhere in the world. So make sure that your data collection is extremely ethical. Obviously, I'm concluding in a couple of minutes. As far as the research conclusion or the randomized clinical trial conclusion is that it should be able to, your results should be able to answer the primary objective and the secondary objective, and your conclusion should always be based on the results. There should be no conjectured conclusion. It has to be what your results are, and you should be able to answer all your objective based on the results is what a conclusion is. You cannot conclude something which your results have not shown. So it cannot be 2 plus 2 as far as conclusion is concerned. So it should be answering all your objectives based on the results. So that is what is exactly the conclusion of your randomized clinical trial. As far as the research accumulation is concerned, obviously it has to be published, because doing an RCT and not publishing is wastage of time and effort. So please make sure that the research accumulation should be that you get it kind of published in the end. Let me tell you, what did I tell you? I told you that spent a lot of time as far as the research question is concerned. I told you the types of trial designs. I told you that you must have randomization. I told you that protocol registration is there, training and calibration. And I would also want to tell you that make sure that you begin with the end. Begin with the end in mind. Is that you would require to publish. This is something which has been very useful for me to make my randomized clinical trials. I've been telling my postgraduates that if you are looking at making a kind of a randomized clinical trial, in the beginning itself, refer to the consort or the PIRATE guidelines. I'll repeat this. If you are planning to do a randomized clinical trial, go down to the PIRATE guidelines, because those are specifically for endodontics. Forget the consort, go down to the PIRATE guidelines and make sure that you have all the checklist when you are designing that randomized clinical trial. If you do this at the beginning of your randomized clinical trial, you will never go wrong. You see, I may skip something in my presentation, or while the guide may skip something while making the protocol. But if you have referred to the pyrite guidelines at the time of making your protocol and incorporated everything which needs to be there, then you are definitely doing a good quality randomized clinical trial, and you're not going to be missing anything. So that's what my message here is, that make sure that you refer to the guidelines at the time of making the protocol and not at the time of publishing, because if you refer them at the time of publishing, you may have missed a lot of things or few of the things, and you'll never end up publishing because that trial may not be valid. So the take office message out of everything is, make sure that you are there with these guidelines at the time of making the protocol, is what would I want the message to be there for you guys. Obviously, we have the best material and the best brains in this country. This is on a philosophical basis. I'm trying telling you that today India is standing, as far as endodontics is concerned, in highest platform. Be sure onto that for the postgraduates, that we've rarely come across from the 80s and 90s to now. We have the best brains and we have the best clinical materials. So I want that you do the best quality trials. Doing in vitro studies today, please, I go to a lot of colleges and say the same thing. Please do not mind me. Doing in vitro studies for the sake of thesis is just for the sake of thesis. If you're really looking at doing justice to your thesis, then let it be a trial, because one, you're generating evidence, and somewhere or the other, you're helping the patient because we are treating them. And it's the best thing you can do is to do a trial, maybe an observational study, and obviously the highest level comes with this. And the other thing which I need to tell you is that make sure that when you're doing these trials, make sure it's feasible. It should be original, otherwise you will not get it. It has to be relevant. It has to be comprehensive. It has to be ethical. What do I want my endodontist postgraduates? Learn good root canal, but learn to do good trials also. As you see, Government of India is making a whole cadre now, which is ready to be ready in research. And if you get hook of it, this in the postgraduate program itself, you would be somewhere an asset to the specialty as well as to dentistry, is what I would understand. I am there. Thank you. I had 1 hour. I started 10 minutes late, but I'm on time. Thank you very much, madam. I hope I've been able to make everybody understand what I wanted to tell. Thanks.